I would like to invite Dr. Pooja Khamar to talk about epithelial mapping.
Thank you everyone, and I would like to thank Mohita ma'am and her entire team for inviting us here. So as my previous three speakers have highlighted the role of PRK in their practice and also where epithelium can be utilized, I'll just go a little bit into detail of it and also show maybe few examples of how it can affect us. So when you see when you see a refractive surgery patient, your topographies may look normal, but you may see these different varieties of epithelial. Now, is epithelial really important? Do we consider all these profiles differently or just consider them as one and go ahead and treat and do a trans PRK? So what ma'am has spoken about, ma'am and Arushi have spoken about the Tenio 317. I will throw a little bit highlights into the Schwinder Maris, but also whatever I'm going to say is considers equally for other machines as well. So whenever you have a differential epithelial thickness, there is an option, you do the PTK mode based on the epithelial thickness. Now if I put a uniform epithelial thickness here of let's say 55 in both, then in the periphery, I may have an undercorrection by 4 to 5 microns, which may lead to around 0.5 diopters of regression. And if I just put, let's say here it's 60, if I put 60 here entirely, but as the center is around 54, I am overcorrecting, I am ablating 6 microns more, which may lead to an overcorrection. That is why epithelial mappings are very important if you are doing a trans PRK. If you are doing a manual removal of epithelium, then it doesn't matter because you are going to remove it with probably a scraper or a alcohol-based approach. But if you are doing a trans PRK, which is with laser, 1-step or 2-step, epithelial mapping does play a very important role because of these differences, and this can lead to an overcorrection or undercorrection of 0.5 to 1 diopter. So, and you can get this epithelial thickness map from any tools, like you can have MS39, you can have OptoView, you can have the Zeiss Cirrus OCT, multiple other factors. The second factor, epithelial, helps us to know whether it's a regular cornea or irregular cornea, and whether the aberrations coming are on the higher side or not. So you can go to the PRK mode and you can go to the topo guided mode. This also can be done in every machine. You have an Alcon, you have a Tenio, you can, or Medline, you can do it on them. You just have to put 0 refraction, and after 0 refraction you have to see how much is the ablation. Now here, without putting any refractive error, the machine itself is treating 4 to 6 microns in both the eyes. That means I am probably going to correct the patient by 0.5 diopters, and I have to compensate when I am doing a refractive error correction. So that's why it helps a lot. And if you do a trans PRK, like whenever you have epithelial issues, a lot of times we get a question like, what procedure should we do? Should we do a flap-based procedure? Should we do a lenticle-based procedure or a PRK-based procedure? I would suggest to be doing a PRK-based procedure, because there you are removing the unhealthy epithelium, and when the new epithelium grows in, it's much more regularized and remodels in a proper way if you give proper medications. So that is why probably a trans PRK would work the best when it comes to doing the PRK in irregular corneas. So how does it help? Why is epithelial remodeling very important? Because if the epithelial remodeling is regular, then you can see here how post-operatively epithelium will look like, and that will give you a good quantity of vision and a good quality of vision and a clear cornea also. But if you have an irregular cornea, irregular epithelial map, then you can probably have a poor quality of vision, which I think I'll come to the next slide. So now if you see this patient, this is a 28-year-old female patient who wants a refractive surgery opinion. The topography looks fairly normal. The Kmax is of around 47.1, but otherwise everything looks fine. But if you see the epithelial map, you can see that this is an O sign. This is a C-shaped epithelium, and this is almost a donut or an O-shaped epithelium. So this is actually a sign of extremely irregular epithelium. And here, if you see, the center is 52 and the periphery is 62. So there is a difference of 10 microns. Now, if I just put it here as 50 and treat it, then again the periphery is going to go into undercorrection. Or if I put 65 or 60, let's say, for the entire area, then it may have an overcorrection. So that's why an epithelial map is very important to choose what epithelial thickness to put. And as I was suggesting before, if I treat the epithelium, irregular epithelium just like that, what would happen? Whenever the epithelium is irregular, we don't have this tool right now, but it's under process, and it's there in MS39, and other topographers will also have it. Whenever the epithelial aberrations are on the higher side, epithelial irregularity is there, the aberrations also will be on the higher side. So it's not just the epithelial irregularity you are treating, they also account for some amount of aberrations. So it's not just the total corneal aberrations, the aberrations may come from the epithelium as well. So an irregular epithelium is a sign of high aberrations, and if you go out and do a treatment on these patients, post surgery you may land up into a high induction of these aberrations. And you can see here, this is the same patient. The corneal wavefront analysis shows that the cylindrical error in the cornea is 0.99, but just the 0.41 is coming from the epithelium. So that's why it's very important to choose that. And what will happen if I treat, this is a post-operative epithelium. If I treat it, the induction of the aberration is going to be on the higher side. Now, why so much about epithelium? Because as I mentioned, this was my first slide. If there is an irregular epithelium, that means your corneal nerves are unhealthy. It's not just your ocular surface issue, but underlying your corneal nerves are unhealthy, and you can have something like a dendritic cell, or absence of nerves, or a microneuroma, or you can have multiple mature dendritic cells. And if you do any surgery, let's say PRK, LASIK, SMILE, or cataract, so it's not about PRK, but if you do any of this procedure, then post-surgery there is going to be an exaggerated wound healing response, and these patients are going to have, because there's a lot of irregularity, these patients are going to have a poor quality of vision. You can see how irregular the epithelium is. There's a severe epithelial hyperplasia, and that is what is going to lead to a poor quality of vision. So your patient may still have 20/20, but because of the epithelial profile and irregular remodeling, the patients may be unhappy, and you might wonder what has happened. The other reason what is important is in an irregular epithelium, that is also a sign of ocular surface inflammation. And if you just go ahead and do a refractive PRK procedure, they may develop corneal haze post-surgery, because whenever you have pre-existing inflammation, even if you use mitomycin C or you give proper lubrication and all everything after surgery, these patients are at higher risk of developing post-PRK haze. So that is why epithelial mapping is extremely important. Now, how do we treat this patient? This is a scoring which is known as the perfect scoring, where you predict, examine, treat, follow up, evaluate, and give a chronic treatment to reduce the chances of post-PRK haze. So even if your epithelium is irregular, or if there is a lot of irregularity, you will pre-treat them with steroids, cyclosporin, or lubricating drop, and post-surgery also you'll put them on a sodium hyaluronate based drop, and cyclosporin for at least 6 months, and that will have a good epithelial remodeling, so you will not have a pseudo regression or a hyperopic shift, and also the quality of vision is going to be good, and it reduces the chances of haze. Thank you.
Thank you, Dr. Pooja. I just wanted to ask you, is there a way of finding out whether the aberrations are corneal or the aberrations are below the cornea?
Epithelium is so in your normal topographers, it will give you the total corneal aberrations. But if you have an epithelial map, even if you don't have epithelial aberrations, if there is a lot of irregularity like how you saw in these maps, that means there are epithelial aberrations present, and you have to pre-treat them and then take them up for surgery and have a customized epithelial removal treatment plan.
Because that epithelium is going to get removed. Anyway,
Yes.
you're getting rid of those aberrations. So how would you calculate how much of aberrations to treat?
So epithelium is going to get removed. So that is why the PR in such kind of cases, PRK is the best procedure, because you are removing the epithelium. But if you do a PTK, let's say of 55 microns, but my thickness is variable, that's when I will land up into a refractive surprise. So that is where the problem is going to come. So a refractive surprise like a residual cylinder is a sign of a coma or trefoil, because comas and trefoils combine together to make a cylindrical power.
So basically, we need an instrument which can separately tell us.
If you do not have it, and if you're doing a PRK, probably go ahead and do a manual removal of epithelium. But if we are doing a trans PRK, I think an epithelial tool is must, because the refractive surprises or this scenarios of a poor quality of vision or haze may just be around 2 to 3% patients, but those 2 to 3% patients are going to make our lives extremely difficult. So if you are doing a trans PRK, I think epithelial map is important.
And maybe the amount of aberrations that you are seeing, since they are because of epithelium, you may not always want to plan a customized treatment. You can just
Yes.
remove the epithelium and do an aspheric treatment.
Yes, you can always do that. So if you're doing it, but again, a 2-step procedure is also okay, but you'll need like a customized epithelial treatment plan. Like center, you remove 55, periphery 65, or vice versa. So that's the only challenge. I know it's little overdue, but that is what we have been
The
seeing.
best possible.
Yes.
Yes. Thank you, Pooja.
Thank you, ma'am.
That was
Thank
a
you.
wonderful presentation.